This is the second video in a series on protein needs and disease states. It explores how cirrhosis and chronic kidney disease affect protein turnover, and it provides recommendations for intake. Now that we've learned some basics of protein metabolism in the body, reviewed the RDA of 0.8 grams per kilogram per day, and discussed protein recommendations for older adults, we're moving on to protein needs in specific disease states. The intention here is not to provide a comprehensive overview of each disease. It's really just to provide an answer to two questions. How is the protein turnover affected, and what's the recommended protein intake for the patient population? We'll get started by looking at cirrhosis. Cirrhosis is a form of chronic liver disease in which the normal tissue of the organ is replaced by fibrous connective tissue. This results in a progressive decline of liver function, meaning the disease worsens over time. Since the liver plays a central role in nutrient metabolism, cirrhosis presents a number of challenges to processes like the synthesis, storage, and disposal of compounds that are necessary for survival. These challenges contribute to the development of complications like ascites, hepatic encephalopathy, micronutrient deficiencies, and the gradual loss of skeletal muscle. The gradual loss of skeletal muscle in cirrhosis suggests a persistent shift in protein turnover toward protein breakdown. In some cases, this is easily explained by an absolute lack of total energy and protein, leading to similar reductions in adipose tissue and muscle tissue. However, in many cases, muscle loss exceeds fat loss, or occurs without significant fat loss, pointing to unique issues with protein metabolism. For this video, I've identified 5 factors that contribute to the gradual loss of skeletal muscle with cirrhosis. While these factors sometimes occur in isolation, it's most appropriate to think of them as a constellation of factors that are interconnected. The first factor is accelerated starvation. Under normal circumstances, the liver takes excess glucose and converts and stores it as glycogen. That glycogen is then broken down during periods of fasting to maintain blood glucose levels and preserve the function of the brain and other glucose-dependent tissues like red blood cells. But there's only enough glycogen storage in the liver to last approximately 24 hours. As the liver glycogen is exhausted, there's an increased reliance on gluconeogenesis, for which a major substrate happens to be amino acids. Because cirrhosis results in a lower capacity for glycogen storage, the body is forced to rely on gluconeogenesis for energy much sooner than it typically would. A major supply of the amino acid pool, as we've already laid out, is the skeletal muscle. The second factor is systemic inflammation. Patients with cirrhosis usually present with a marked increase in pro-inflammatory cytokines like tumor necrosis factor alpha and interleukins 1 and 6. These are catabolic factors since they promote protein breakdown and inhibit protein synthesis. The third factor is the accumulation of ammonia. Ammonia is a normal byproduct of protein breakdown, and yet it's toxic to the body. In healthy individuals, the liver is primarily responsible for handling it. It does this by converting it to urea, which is then filtered by the kidneys and excreted in urine. Cirrhosis, especially in its later stages, impairs this aspect of detoxification. This leads to an accumulation of ammonia in the bloodstream and an increased uptake and metabolism of it by the skeletal muscle, where it's believed to promote protein breakdown and inhibit protein synthesis. The fourth factor is hormonal disruption. Patients with cirrhosis often present with insulin resistance, low circulating levels of insulin-like growth factor 1, and resistance to growth hormone. Testosterone is also reduced in males. All of these can be considered anabolic factors, so none of the changes work in favor of protein synthesis. Finally, the fifth factor is muscle disuse. Patients with cirrhosis experience symptoms like weakness and fatigue, and some deal with ascites and hepatic encephalopathy, which all decrease their functional status. Thus, it's common for them to be unable to participate in an exercise regimen, causing them to miss out on the muscle stimulation that's vital to the preservation and growth of muscle tissue. Together, these factors work to keep the balance of protein turnover shifted in favor of protein breakdown. Others mentioned in the research on this topic include malabsorption stemming from complications related to portal hypertension and pancreatic insufficiency, and protein losses from paracentesis to manage ascites. To investigate recommendations for intake, I looked at the most recent guidelines from the American Association for the Study of Liver Diseases and the European Association for the Study of Liver. These were published in 2021 and 2019 respectively. Then I compared them to the recommendations in Nutrition and Pathophysiology by Nelms, 4th edition, as well as the Aspen Core Curriculum, 3rd edition. The reason I want to be upfront about this is because there's an overall lack of consistency in the recommendations. It seems like there isn't a broad consensus on the appropriate ranges for protein intake, or whether to use actual body weight or ideal body weight. After careful consideration, I've decided to adopt the recommendation from the European Association and the Nelms textbook. I don't like the recommendation from the American Association because it's based on ideal body weight, and I find it drastically underestimates the needs of patients with larger body sizes. Then I also don't like the recommendations from Aspen because the lower end of 1.0 grams per kilogram per day sits below any recommendations I've seen elsewhere in the literature. When using actual body weight, ascites should be accounted for as needed through the assessment of recent weight history and/or by obtaining a new post-paracentesis weight measurement. Although energy needs are not within the scope of this video series, achieving adequate energy intake to at least promote weight maintenance is necessary to minimize protein breakdown. Last but not least, a protein recommendation greater than 1.5 grams per kilogram per day may be necessary if the case is confounded by other acute or chronic medical conditions, including severe malnutrition. Before we move on to chronic kidney disease, there are 3 more aspects of cirrhosis that I want to touch upon. The first one is hepatic encephalopathy. It was previously believed that the appropriate treatment was a protein restriction to well below 1.0 grams per kilogram per day. The theory behind this was that protein adds to the ammonia level, so by removing it, you'd see a reduction. Today, the consensus is that there's no benefit to restriction since it's met by increased protein breakdown in the body, which produces ammonia too. This comes with a warning that restriction may cause harm by accelerating muscle loss. The second one is meal frequency. Across all guidelines and textbooks, it's agreed that shorter fasting periods are necessary to account for accelerated starvation. Patients should aim for protein and carbohydrate-rich feeding sessions every 3 to 4 hours when awake, and reduce the overnight fast as much as possible by eating right before they go to bed and soon after they wake up. The third one is branched-chain amino acid supplementation. This has been looked into as an option to promote protein synthesis in daily use and as a treatment for hepatic encephalopathy. Even though the branched-chain amino acid leucine is needed to activate mTOR, ultimately all of the amino acids are needed in adequate amounts. Research on branched-chain amino acids for hepatic encephalopathy, including a 2017 Cochrane meta-analysis of 16 randomized controlled trials, has shown they can produce a small improvement in symptoms. However, this benefit appears to be insignificant compared to lactulose, which is the gold standard for treatment. Overall, clinical use remains low. It's not recommended by the American Association, and it's only recommended by the European Association if adequate intake from food isn't achieved. If you're enjoying this video so far, make sure you hit the like button, subscribe to the channel, and share it with a friend. All of these actions help me to reach and help more people. Chronic kidney disease is up next, and to make this simple, from here on out I'll just call it CKD. CKD is defined by abnormalities of kidney structure or function that persist for greater than 3 months. Like cirrhosis, it's a progressive disease, meaning it worsens over time. That progression is marked by 5 different stages, and each stage is characterized by values for the glomerular filtration rate, or GFR, which is a proxy for how well the kidneys are working. By the time CKD reaches stage 5, it's considered end-stage renal disease. At this point, renal replacement therapy is needed to survive. This is the term for a group of procedures, the most common of which is hemodialysis. Unlike cirrhosis, where we had a uniform discussion of the factors affecting protein metabolism and produced a single recommended range for intake, CKD must be broken down into 2 parts. We have pre-dialysis recommendations, which account for CKD stages 3 to 5 for patients not on dialysis, and we have recommendations for patients on dialysis. With the pre-dialysis patients, the goal is to slow the progression of the disease to minimize risk of complications and delay the need for dialysis. Here, the patients often benefit from protein restriction to the lowest amount needed to achieve net protein balance. Then with the dialysis patients, the goal is to preserve the skeletal muscle. These patients present with a high rate of muscle wasting and have increased protein needs. One of the primary roles of the kidneys is to filter the blood and assist in the removal of waste products. The main waste product is urea, which we've already seen in this video because it's produced by the liver to get rid of ammonia. A healthy adult has millions of nephrons, and for these individuals, the filtering of waste to create urine is an extremely efficient process. But with CKD, where there's a progressive loss of functional nephrons, the total filtering capacity is reduced, and those remaining are forced to take on a higher workload. Although initially there are compensatory mechanisms to handle these changes, it seems that eventually the higher workload causes damage. Producing a greater amount of urea through a high-protein diet appears to accelerate this process. Then in the later stages of CKD, kidney function becomes so poor that waste products and other harmful compounds don't get filtered and begin to build up in the bloodstream. Complications like metabolic acidosis and systemic inflammation ensue, and both promote protein breakdown. With this, we can see a clear connection between a high-protein diet, worsening kidney function, and protein breakdown. Recommendations for intake with CKD come from the National Kidney Foundation's Kidney Disease Outcome Quality Initiative, also known as KDOQI. In 2020, they produced clinical practice guidelines for nutrition as part of a joint effort with the Academy of Nutrition and Dietetics. For patients with CKD 3 to 5 not on dialysis, the guidelines provide separate recommendations for patients with diabetes and patients without diabetes. The recommendation for patients with diabetes is 0.6 to 0.8 grams per kilogram per day. The recommendation for patients without diabetes is 0.55 to 0.6 grams per kilogram per day, or 0.28 to 0.43, with a supplement of keto acid analogs to achieve a total intake of 0.55 to 0.6. These analogs provide the essential amino acids without nitrogen, so they can be used in the body without contributing to ammonia and urea production. In terms of the difference in recommendations based on diagnosis of diabetes, I couldn't find an explanation for it in the official document. Nevertheless, it's discussed in another recent publication from the National Kidney Foundation. In this document, they mention that a patient with diabetes may have been counseled to limit carbohydrates, fat, and alcohol, and that adding another layer to the restriction may lead to significant weight loss and a decrease in quality of life. Then we have the question of what if the patient also has blank? Go ahead and insert your disease state of choice. Obviously, if a patient has CKD and another condition where protein needs are increased, it creates a conflict. Thankfully, the KDOQI guidelines address this matter by stating that the recommendations are for patients who are metabolically stable. According to the text, this includes the absence of active inflammatory or infectious diseases, hospitalization within 2 weeks, poorly controlled diabetes, consumptive diseases such as cancer, antibiotics or immunosuppressive medications, and significant short-term loss of body weight. So, it seems pretty clear that any condition that shifts the body in favor of protein breakdown takes precedence over an attempt to delay the progression of kidney disease. After all, the implications of muscle wasting, poor wound healing, and a decreased ability to fight infection are much more immediate threats to life than having to go on dialysis sooner. In the end, it's imperative to balance the preservation of kidney function with safety, while also taking into account the patient's goals of care. Once a patient is on renal replacement therapy, there's no longer a need to preserve kidney function. As I mentioned previously, the most common form is hemodialysis. This is when blood is filtered outside the body using an artificial kidney machine. A second, less common form is peritoneal dialysis. This is when blood is filtered in the peritoneal cavity, and then the fluid is extracted and discarded. Other forms fall under a category of continuous renal replacement therapy. These are used in the critical care setting and are beyond the scope of this video. The dialysis fluid used in hemodialysis and peritoneal dialysis, also known as dialysate, is designed to extract waste and any excess water. But it will also pull out some glucose, amino acids, body proteins, vitamins, and minerals, among other compounds. On the one hand, removal of nutrients like potassium, phosphorus, and magnesium is often beneficial because they accumulate to toxic loads. On the other hand, removal of glucose, amino acids, and body proteins will be problematic if they aren't replaced through dietary sources. Estimates of protein losses in dialysis are variable, and much of the available data is from the 1980s. Looking at the limited number of studies from the year 2000 and on, it appears that protein losses during a session of hemodialysis are somewhere between 7 and 15 grams. Losses from peritoneal dialysis are right in the same ballpark. However, peritoneal dialysis is usually performed daily, whereas hemodialysis is usually only 3 times per week. Even though this makes it seem like peritoneal dialysis results in greater total losses, the procedure for hemodialysis has been shown to cause acute systemic inflammation, with an increase in interleukin-6 and cortisol. This suggests that it promotes protein breakdown beyond what's lost in the dialysate. All things considered, these factors likely cancel out the fact that peritoneal dialysis is performed daily. Recommendations for intake from KDOQI are 1.0 to 1.2 grams per kilogram per day for patients on maintenance hemodialysis or peritoneal dialysis. This reveals a departure from the guidelines published in 2001, when they recommended 1.2 for hemodialysis and 1.2 to 1.3 for peritoneal dialysis. Unfortunately, there's no discussion of this change in the text. In the detailed justification section, they even offer a contradiction by stating that the KDOQI guideline for dialysis patients suggests dietary protein intake greater than 1.2 grams per kilogram body weight per day to manage the protein catabolism and losses of protein in dialysate. The only explanation that I can come up with is that they made a mistake. Then I go back to the recommendation where they say it's for patients on dialysis who are metabolically stable. To which I ask, is any patient on dialysis metabolically stable? Given what we saw for nutrient losses and systemic inflammation, I'd argue they're not. Without clear guidance, I think that going with a minimum of 1.2 grams per kilogram per day is appropriate, and I would go higher if the patient has inadequate energy intake, evidence of muscle loss, or other medical conditions that also increase demand. Since end-stage renal disease is also associated with fluid accumulation, effort must be placed toward finding the most accurate dry weight possible. This can be done by examining recent weight history and trying to obtain pre- and post-dialysis weights. Now we can go ahead and add these conditions to our chart. For cirrhosis, we have 1.2 to 1.5 grams per kilogram per day, and we must consider fluid shifts with ascites. A protein restriction to assist in the management of hepatic encephalopathy is not recommended. Then for CKD stages 3 to 5 not on dialysis, we have 0.6 to 0.8 for patients with diabetes and 0.55 to 0.6 for patients without diabetes. Patients without diabetes can also be considered for 0.28 to 0.43 with a supplement of keto acid analogs. For end-stage renal disease on dialysis, we have 1.0 to 1.2 according to KDOQI, but with dialysis being a catabolic event, I feel that an intake of at least 1.2 grams per kilogram per day is more appropriate. Like with cirrhosis, we must consider fluid shifts. Coming up, we'll continue to map out protein needs in disease states by looking at pressure injuries and critical illness. Thank you for watching, and I'll see you in the next video.